Okay. Let's start by talking about a famous Spanish guitar player, flamenco guitar player, Carlos Montoya. And he's famous, and he's explosive, and he's good, and he's the master of his music. But in my opinion, he does not have the ability to follow a woman as she dances, which is the key to it all. And the woman is the patient. Think of it in another point of view. One time I was at Disney Hall, and here is this really nice Russian lady playing the piano, and here's the conductor and the orchestra. And the lady is the soloist. The conductor controls the orchestra, but he follows her and suits the whole behavior of the orchestra to her needs and her movements at the time. That's what individualized therapy is about. We will see that there's a whole bunch of mathematical techniques that are developed to track the behavior of serum drug concentrations in patients and to put them where we would like to put them, where we think a patient should have certain drug concentrations at certain times. And a lot of what we have done does not come from the biomedical community, but it comes from the aerospace industry and from the military. And it uses the same approach to track enemy fighters taking evasive action, just like you track the lady as she dances, so that you can shoot them down the best, so that you can use the dose as the gun to hit most precisely the serum level that you want the patient to have. So those are the basic techniques that we have been using. This evolved over many years. But with digoxin and lidocaine and the aminoglycosides and vancomycin and busulfan and methotrexate, there's our lab. Alan Shumitsky is professor of mathematics at USC, and David Bayard works in the guidance and control section at the Jet Propulsion Laboratories in Pasadena, where they manage all the unmanned spacecraft. And here is Michael Neely, who is our new director, and Ida Bustad makes everything happen, and Mike Van Gilder is our main scientific programmer. And so for digoxin, a number of years ago, many years ago, before serum assays were developed, we were able to do 90 evaluations in 84 patients who were on intuitively managed therapy at the time, and 36% were toxic, with 2 deaths. And this was the calculated total concentration of drug in the patient's body. The survivors on our regimens had less, and they had much less toxicity, and 1 death, but a very significant reduction. And another prospective group had only 1 episode of toxicity, no deaths, and this is more the concentration that's associated with therapeutic serum levels now. And if you look at it from the point of view of a physician in practice in a community hospital, you might say that the intuitive therapy group, who had this much, had this many manifestations, and let's round that up to 2 episodes per patient per year. And that would be a good deal. And here the survivors had a whole lot less, and the prospective group also had a whole lot less. So that if you were a community hospital physician with a standing caseload of 6 patients in the hospital at any time, you would have, let's say, 2 times 6 patients is 12 episodes a year, 1 a month, and you would say, oh yeah, I see it now and then. Not realizing that you can really make it a much rarer and infrequent thing. So that's digoxin. And for lidocaine, we were able to take the incidence of conventional therapy with this number of patients with ventricular fibrillation to only this. And these were the only 2 who required more lidocaine, compared with 33 in the intuitive group. And so this is a significant improvement also in therapy. And for the aminoglycosides, here we see the predicted and measured serum concentrations in patients in our respiratory ICU in County Hospital a number of years ago. Then here we see the predicted concentrations here in France in Dr. Pascal Mayer's hands. And here they are after fitting the first cluster. This is predicting the second cluster of levels based on here not fitting and here on fitting the data of the first cluster. And so this shows us then that monitoring serum levels this way really significantly improves our ability to achieve the serum levels that we would like them to have. Sander Vinks at the University of Cincinnati, when he was back in Holland in 1999, had that many patients, and this many had significant infections on admission. The peaks were higher than in the ordinary TDM. The ordinary TDM was the physician got the data and used his judgment in the therapy. Here, in the actively treated one, software was used to guide the therapy. And the troughs were lower. And the mortality was somewhat less in the overall group, but the mortality was significantly less in those with significant infections on admission. And that's one of the nicest demonstrations of the use of therapeutic drug monitoring, coupled with software to individualize dosage regimens. The actively treated group had less nephrotoxicity. Hospital stay was shorter by about 6 days, with a significant saving in money. For vancomycin, here we see the usual linear regression on the logs of the serum concentrations versus a 2-compartment model and Bayesian fitting. Much better ability to predict the second cluster based on fitting the first. And if you want to give it continuously IV, it's a big improvement also, because if you want to get a trough of 12, you should give 4 grams a day if you're going to give it once a day, 2 grams, 2 grams every 12 hours here. Here is progressively less and less and less, and here for continuous IV, you're down to 1 gram a day. And that's a big saving in the exposure of the patient to a potentially toxic drug. And it does as well as the intermittent therapy. For busulfan, Nathalie Blazak in Lyon in France had that many patients. Veno-occlusive disease was significantly less in the actively treated group. Graft failure was 0. Survival was significantly better. And here we see with cyclosporin in pediatric bone marrow transplantation that there was no basic dose-effect relationship, but there was a relationship between the trough levels of cyclosporin and the grades of graft versus host disease. And they found good target blood concentrations specific to each type of graft and each kid's problem. And so the empirical strategy was to change the doses if the serum levels are significantly different, and oftentimes more than a week is needed before finding the right regimen. They used their pharmacokinetic models and our older version of our software, and compared their Bayesian monitoring with empirical monitoring gathered from an examination of the other activities in France. And they looked at the costs, and they found in 85 children from their place, and they compared that with 100 papers and wound up with studies of at least these were the search criteria that they used. And they wound up with 9 studies to compare with theirs. And they found that the cost of one episode of severe graft versus host disease added 102,000 euros for each patient. And the cost of carrying that out were this number divided by 3.7, so about 30. So they wound up saving about 70,000 euros for each episode avoided in that situation. And here she says that in April of this past year, that the French Agency of Biomedicine released their data of pediatric bone marrow transplantation, and their people were the best center in France with the lowest transplantation-related mortality and the highest one-year survival. And obviously it was a teamwork, but she says that the contribution of the drug dosage regimen's individualization was clear for busulfan, antibiotics, voriconazole, antivirals, and immunosuppressives. And they have the best disease-free survival in the world for children transplanted for leukemia, thanks to the Bayesian monitoring of cyclosporin, and they have another paper out about that. So she says, thanks to our guys for individualizing the doses like this and giving them the tools. Anders Asperg in Oslo at the Rikshospital, where they do all the kidney transplants for Norway, has shown that the use of the best dose software did better than their experienced transplant physicians in optimizing the doses of tacrolimus. And they also showed that it was useful to include the genetic information in the population model, but after you had taken 3 or 4 serum concentrations, you had learned everything that you would have known anyway. And it really pays to look at the behavior of the drug itself so that you will see the effect of all the genetic abnormalities that we have discovered and all the ones that we haven't yet discovered, and all the drug interactions that we know of and all the ones that we do not yet know about. It really is useful to look at the actual behavior of the drug itself. And Bayes' theorem describes the relationship between the prior probabilities of something, getting new information, and the way that new information revises our probabilities after we know that. And that's what the software is designed to do, and we try to do it optimally. Now, many people use parametric models and use maximum a posteriori probability Bayesian analysis. And it's good. And it fits over the entire dosage history. You don't need to wait for a steady state, which is a big plus. You can add new data as it becomes available. It's not limited to one compartment models. You can handle the correct description of the assay credibility. And the data can be at any time, not just post-distributional. And it also supplements it with what we know from past experience in the form of a population model. And it does not need 1 point for each parameter to be fitted. And we can fit with only one data point if needed. The results are not as good. More information does better, always. It tends to be a better predictor than non-linear least squares. Here's the Reverend Thomas Bayes, who died in 1761. And it's his work from this Presbyterian minister in Anglican England who developed this theorem that, not Pascal, the other guy whose name begins with P, I can't remember, gave him the credit for. And here we see that we are minimizing the difference between the observed concentrations and those predicted over the variance of each observation, plus the observed difference between the parameter values in the model versus the population over the variance of the population parameters. And so we start with our population model, we get our serum concentrations, we optimize our objective function to make an individual model, and then we look at the patient and we think, and we set a goal, and then we calculate the doses to achieve that goal most precisely. This is in a parametric form. We now do it in a non-parametric form, which lets you do this specifically with maximum precision. And here we see what we saw before, and again, what we saw before. Now, the limitations of that are that you assume that the probability distributions in the population have normal or log normal, for example, parameter distributions. And the action taken is only based on the central tendency and not on the full parameter distribution. And there is this thing called the separation principle. And it says that whenever you separate the process of controlling a system, any system, shooting down a plane, into first getting the best single point parameter estimates and then using those to control the system to hit the target, you do it suboptimally because there's no performance index like precision that is specifically optimized. Now let's go to non-parametric modeling approaches. And we talk about the variability now between people. And usually the parametric people describe it with a single number. But you can have specific subpopulations, fast and slow metabolizers in different proportions. And it's very difficult, it's impossible, to describe all that with a single number. And the variability within a patient over time is the assay error pattern, the error of the assay, plus the errors in recording the times that the doses are given and the samples drawn, the errors in the actual size of each dose given, the errors in recording the dosage times, the misspecification of the mathematical model that we are using, and unrecognized changes in parameter values during the data analysis. And we'll come back to that later on. Here we see the assay errors. And here we see that the assay standard deviation is the important thing, not the coefficient of variation that the clinical labs all persist in using. They close their eyes to anything in any statistics book, and they continue to do it in their really, I'm sorry to say, silly way. But here you can get the correct measure of credibility of an assay and use that so that you get the right parameter values in your model so that you can give the best dose. Here you see a population model, and the parameters are forced into this so-called normal curve. Here we are. It looks very scientific, but this is more real life. And our problem is to describe that kind of uncertainty and that kind of data. And what would be the ideal population model that you could ever make? It would be somehow to know each subject's model parameter values exactly. Pick up the red phone and call God, and he will tell you the exact parameter values for each patient. And that would be the best you could do, and you'd have one model for each subject. And the usual statistical summaries based on normal parameter distributions would lose you information from the richness of the discrete distribution that you now have achieved. And the best approach is the non-parametric approach based on these guys' theorems. And here's an example from Alain Mallet in Paris, who's really the father of non-parametric population modeling in the early 1980s. And here we see that the size of the dot, this might be the volume of the rate constant for elimination, and this is the volume of distribution, and the size of the dot reflects the probability of that point in the population. And so here we see that this is not a normal distribution at all along this axis. But this is a problem that you have in real life of finding the dosage recommendation based on what you know about your individual patients in the past to achieve a target goal for the new patient with maximum precision. And how do we go about that? So non-parametric models get the entire maximum likelihood distribution. It's a discrete, not a continuous, but a discrete joint density. And the shape of the distribution is determined only by the data itself. So you have multiple models, up to one model set per subject, and you can discover and see unsuspected subpopulations, like we saw with the two clusters in the blue slide. And the multiple models now permit multiple predictions into the future. And so you give a dose, a test dose, a candidate regimen to each model support point, and it generates a prediction into the future weighted by the probability of that support point in the population. So now you can compare the predictions of each support point with your target. It's easy to calculate the weighted squared error of the failure of that regimen to hit your target, and you can find the regimen that specifically minimizes that failure. And that is the maximally precise regimen. It's called multiple model dosage design. Multiple model adaptive controllers are in every commercial flight control system that you fly on. And it's nice to have one sample for each model parameter estimated. Steady state trough levels are not informative. Here is an early version of our non-parametric population model using all these serum samples in the data. There it is with fewer serum samples, and there it is with only troughs, so that you see how important the data is to what you get. And when you use minimally informative data like steady state trough levels, you are not learning much about your patient. Here is a simulation, and here we have a group of patients who are fast eliminators and slow ones, and here is the truth. Sampling this population randomly to get 20 subjects, here's the truth with those subjects. So the job of population modeling now is to discover this truth. If you use parametric methods, this is what you will think is occurring. If you use the non-parametric approach, this is a much better version of reality that you can perceive. And so there are no approximations. You have the guarantee that the more subjects you study, the closer your results will get to the truth. And what about efficiency and bias and convergence and fast or slow? Here we see that Bob Leary studied this question, and he set up these simulation conditions with a one-compartment model and looked at populations of 25, 50, up to 800 with two serum concentrations with a high and a low and a 10% error. Here is the truth. Here is the perception of that truth using the non-parametric model. 70 support points for 800 subjects. Here, as you increase the number of subjects, the good guys, using exact likelihoods, get closer to the truth, the more subjects you study. Here, interestingly enough, the very commonly used procedure in the non-MEM software gets worse as you study more subjects. Very interesting. Here we see the same thing. The good guys get closer to the truth. The parametric approach with the approximate likelihoods at the time gets worse. Here again, the good guys and the approximate likelihood method. And so we see that, and for the correlations, again we see that the approximate method does very, very poorly. And the efficiency, the exact likelihood methods do a good job. The approximate likelihood method does a bad job. Here we see that the two good guys converge with the theoretical maximum approach, whereas the approximate likelihood requires many, many more samples to do an equal job. And so the consequences of using approximate likelihoods are a loss of consistency, no guarantee of the more subjects, the closer to the truth, a loss of efficiency, a reduction in the convergence rate, needing 16 times rather than 4 times the number of subjects to reduce the error by half. But it has a curse of dimensionality. And if you want to estimate parameters with the number of grid points required to estimate parameters with a 1% error is actually 10 billion. So there is a real problem. So what Bob Leary did was to start by solving a problem on a smaller grid. When that was solved, then they threw out extra points, added extra points near the solution, and then did it over again, and did that over and over and over again until convergence. And this was about 1,000 times faster than the previous method, and much less computational effort. And here we see that the adaptive grid is very much better than our first EM method was there. And this is what we use now, and for the last 20 years, this is what we've been using. And we see that for this kind of a problem, an 8-subject, 5-parameter Michaelis-Menten model, NPEM took 2,000 hours, while NPAG took less than 2, and so on. So, and if we look at the efficiencies, direct observation has a 100% efficiency. PEM was 76%, NPAG was 61%, and that's as it should be. And the approximate likelihoods were 29 and 23, and the first order approximation was 0.9% efficient. So that is really, really sad. So the conclusion is that these guys were consistent, and this one was pretty much. Let's go here. The bottom line here is that the non-parametric approach really does the best. And so first, you start by looking at your assay and say, how does your assay do? You quantify the errors in your assay and store them as a polynomial. Then you use the non-parametric model to get your population model, and gamma and lambda are 2 ways of modeling the non-assay components of the environment in which the study was done. And the lambda is the best because it adds rather than multiplies the error. And you can predict the precision of dosage achievement, and now you can find, using multiple model dosage design, the dose that achieves your target goals with maximum precision. Multiple model dosage design. And we've been through the separation principle, you need to use the whole distribution rather than the single point summaries. The whole distribution, the entire one. And you give a candidate regimen to each model. You predict the results with each model. You calculate the weighted squared error of the failure of the regimen to hit the target at that time. And you find the regimen that has the least weighted squared error. This is multiple model dosage design. Now, when should we get our serum levels? What's the best times? We want to get them to check what we've done, but we also want to get them so that we can learn as fast as possible how the patient, how the flamenco dancer is behaving. And we need target AUCs to be precise with good sampling strategies. Methotrexate has been a problem because all that people have been interested in is what the level is when they're thinking about giving leucovorin for rescue. And because of that, they haven't started sampling methotrexate early enough to really understand the true behavior of the drug. That has been a significant problem. Now, when it comes to, again, looking at times to get levels, people have said wait half an hour after the end of the infusion to get your so-called gentamicin or aminoglycoside peaks. No, 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 no. The peak is out of the opposite arm at the end of the IV. And you don't want to waste information by getting your peak at any other time, because the peak is what tells you most about the volume of distribution of your drug. And de-optimal experimental design has been a good method. We now have better methods also, but they're too complicated for here today. But here we see that if there is a change in the volume of distribution, the time at which that makes the biggest difference in the serum concentrations is at the peak, not down here and not down here. In the same way, if the drug is in and it's going away over time, a change in the elimination rate constant makes the biggest difference when the serum concentrations are 36% of the original peak. And so those are basically the two best times, the two de-optimal times to get serum concentrations for therapeutic drug monitoring. People don't do this much, and this is a big area where we can improve our performance with TDM by using optimally designed TDM protocols. If it's given as a fixed rate infusion, the best times are when the levels are all but 36% to a steady state, and then at the end of the study period, whenever that is. For a loading and maintenance infusion, they're at the end of the loading infusion, like with the peak, and then they're at the end of the study period, whenever that is. And if you look at lidocaine, and this was done by David D'Argenio in 1983, I think, and here we see that he found these de-optimal times to examine the behavior of this system here. And so here we see that all 800 patients, two groups, one conventionally monitored and one optimally monitored. This was the time course of the serum concentrations in all 800 patients. And here we see the perceived volume with the conventional strategy, and here with the de-optimal strategy. Look how much more precise the estimates are. Here's the elimination rate constant, the conventional, and the de-optimal. So you can learn much more information with fewer samples this way. Here is the rate constant from the central to the peripheral compartment, and from the peripheral back to the central. So when you get your levels at the maximally informative times, you do learn more. And it's useful to incorporate this into our clinical monitoring protocols for patients. They help us check the achievement of target goals. They help us get good parameter estimates so that we learn about our patients most rapidly. So don't wait for a steady state ever. Start with the very first dose and use de-optimal designs and newer ones that are coming along to optimize our policies for therapeutic drug monitoring. Now, what about the diffusion of drugs into things like endocardial vegetations or into bacteria? Let's examine that and see what happens. Let's think of an endocardial vegetation or a bacterium as an onion that has different layers in it, and we can specify the number of layers, and through each layer, the substance diffuses both in and out. And here we see the time course of serum concentrations for this particular regimen of amikacin. And here we see the predicted time course of amikacin in the center of a simulated endocardial vegetation of 0.5 centimeter. And so there they are like that. And then here, for a 1 centimeter, look how much more damped the concentrations are. And for a 2 centimeter, and look how long it takes for concentrations to reach killing concentrations in those situations. But we can calculate those, and then if you believe this stuff, we can also, and here is in the center of a little microorganism, simulated microorganism, and here we have these equations that we can use now to describe the kill of organisms. Here is the rate of change of the bugs is the growth rate constant minus the killing rate constant times the number of bugs. And the killing rate constant is a Hill model, which has this shape here. And from the Hill model, we can get the EC50 if we know the MIC of the organism. So that's a handy thing there. And we can put those together then, and here we see the calculated kill of the microorganisms on that amikacin regimen when the MIC is 8 micrograms per ml. And here we see it in the center of the 0.5 centimeter, in the center of the 0.5 centimeter endocardial vegetation. And since these concentrations are all above the MIC, we get a good kill. And here the same thing for a 1 centimeter, and here for a 2 centimeter, but look how long it takes. And here now is in the center of that little hypothetical microorganism. There's the concentrations, and there's the kill, since they're all above the MIC. Now here is the concentrations from a patient. Here we see the concentrations in the theoretical little microorganism, and now the MIC is presumed to be 2. And this is for the relationship between gentamicin and Pseudomonas from a study that Pascal Mayer did on data from William Craig in a mouse thigh model. And here we see the effect of the serum concentrations and their failure to kill the microorganisms in the serum because the drug is not there. So it's not just the peak that's related to killing, but it is also the time above the MIC, even for concentration-dependent drugs. It's the time profile. And here in the center of that little vegetation, here we see again that the bugs grow out. Here we see in the beginning the serum concentrations and the concentrations in the peripheral compartment. And we see also the very, very poor fit of this equation to the measured serum concentrations, and we'll come back to that, because this is a highly unstable patient whose pharmacokinetic parameter values are changing during the period of data analysis. And that is the problem with all conventional fitting procedures, is that they assume that the parameter values are fixed and unchanging throughout the period of data analysis. And that's a real problem. Here we see the same thing in the center of a simulated microorganism, and there they are. And here they are again in the with regard to the bacterial kill. And again from the kill in the center of the microorganism. Now, we've had a little trip through this time, and now let's begin to review this and come around again, because it very likely has been a little new to you and strange. So let's come around again and look at this, pretty much the same things, but in a little different way, perhaps. So here's our basic model of a drug, of a patient with a gut and a serum and a non-serum effect compartment, or a non-serum compartment of the drug. And again, we're going to talk about developing maximally precise dosage regimens, using non-parametric models, multiple model dosage design, correct description of assay errors, estimates of creatinine clearance not from a single serum creatinine, but from a pair of changing serum creatinines, so that you can follow the dancer better as she dances her dance in the ICU with all her unstable, acutely ill problems. We're using optimal TDM protocols, and we're using non-parametric Bayesian adaptive control tools. And so here we go again. Again, the same thing, what's the ideal model? And the non-parametric models do the best. There is Alan Mallet's original model. And again, we see the two basic clusters of more rapid and more slowly eliminated drugs. Even if we classify them, we still have the diversity in the classified populations. So our desire is to develop a dosage regimen that is maximally precise based on the total amount of information that we have, which is multiple model dosage design. We don't want to use just therapeutic ranges, because the bottom is not the same as the top of a therapeutic range. We will do better by setting, if you don't know where you want to be, select a specific target in the middle of the therapeutic range. But don't necessarily be restricted to therapeutic ranges, because those are only where most patients, and certainly not all, do well. Don't be afraid to go outside if your patient's behavior tells you that that's where you think you need to go. I've seen patients who required a serum digoxin level of 8 in order to get adequate rate control with their atrial fibrillation. Way, way outside. Social pressures are so great to stay within the so-called therapeutic range that we forget that just like we need to adjust to the MIC, or the sensitivity of the organisms we try to kill, we need to recognize the fact that patients are probably just as variable as the organisms in their response to drugs, and that the target serum level that we select for each patient should not be simply based on what the totality of society says, but you need to go where the patient's behavior takes you. The patient will tell you where they are doing well and where they are not. Follow that. Come on, Roger, get off of this. Now, if you use the mean population values to develop a dosage regimen of IV vancomycin to achieve a target goal of 15 micrograms per ml, and at each of these dots, each of these vertical columns, is where you want to achieve your target goal of 15. If you do that and use the regimen based on the means and give that regimen to each support point from which the mean values were derived, this is the great variability that you will see. This shows you the danger of developing dosage regimens based on means, when in fact, if you use multiple model dosage design, this is what you can get. Much more precise achievement of your goal. And so the dose itself now becomes a very important tool to minimize patient variability in response around a target serum level goal. Now, the assay errors, we want to look at the standard deviation and not the percent CV. And it's easy to do just like now, but use the standard deviation, square it to get the variance, put that in the denominator to get the correct weight. The reciprocal of the variance is the correct measure of credibility for a measurement having a Gaussian distribution of its errors. And the lab guys have their head in their sands for decades not looking at this. Too bad for them. Too bad for the patients that they don't serve optimally. You can store the error in the form of a polynomial this way, and you find that you don't need to censor low data anymore. You will find that the lower limit of quantification is a cultural illusion brought about by the desire to perceive precision as a percent error rather than the reciprocal of the variance. Funny thing. It's an illusion. Here's an assay with a constant coefficient of variation. And here it is, of course, the standard deviation is 0 when the concentration is 0. And of course, that's not true. Then why don't the laboratories give us blanks and tell us the standard deviation of the estimate of the measurement of a blank? What's the noise associated with a blank measurement? They never do that. They never do that. All you have to do is that, so that now you can track the behavior of the drug all the way down to a 0 concentration. And the whole idea of a lower limit of quantification becomes forgotten, is unnecessary. Here is our hospital's assay for gentamicin. Here is the coefficient of variation, and it becomes infinite when the level becomes 0. Here it is with the standard deviation, finite all the way down to 0. No lower limit of quantification at all. And a better, more rigorous definition of the lower limit of detection, because you can then decide how many standard deviations above your mean you will take as some legal requirement for something to be there or not, compared to what they do now. It's really sad, the behavior of the clinical labs. Really, really sad. Now, when it comes to renal function, we know that the clearance is the urinary concentration times the urinary volume divided by the plasma or serum creatinine. We can rearrange that to say this. And so we now know that the creatinine clearance times the serum creatinine is numerically equal to, let's say, the total urinary excretion over a stated time. And here's the reference for it. And what happens if a patient has a sudden change in renal function at this time? The serum creatinine will begin to rise as renal function drops, but it will be a significant time before it reaches equilibrium out here somewhere. So if you use Cockcroft-Gault or the MDRD or any other estimate of creatinine clearance that's based on a single sample, if you take it at this time, you are seeing only that change and you have no idea that it's actually going out here. If you take a pair, maybe here and here, you will do a better job of perceiving this change. But methods that are based only on single samples always give you an underestimate of the change, and it's too late. It's too little, too late. 2 samples is much better. And so here we can say that the change in creatinine production, or the change in the total amount, of creatinine in a patient's body over a selected time period is production minus excretion. And we can say that the change is 40% of the body weight, second creatinine minus the first, and this is production, and this is excretion. Now, we can make a daily estimate of production based on Searsback-Nielsen's data in Copenhagen. Here's the serum creatinines, here's the weight, here's creatinine clearance. And so then we see that the errors in the gold standard, and as far as I know, we're the only group that has looked at the errors in the gold standard, the 24-hour urinary creatinine determination, is 95% confidence limits of 22%, and that's the gold standard. And so here you see our estimate compared with the measurement in the renal transplant books of the patients in the renal transplant unit in our hospital. And here we see that the scatter is very similar to the scatter produced by the error in the gold standard itself. And so here we see that without a urine specimen, in the presence of changing serum creatinines, we are able to estimate creatinine clearance with a precision essentially equal to that of the gold standard. That's why we like to use this in our clinical software, because we think it does by far the better job of any other method that we know to date. We want to optimize our protocols. Don't just check to see what you've done. Don't wait for a steady state. Start with the very first dose. Use D-optimal design. Get a peak and a sample at about 1/3 of the peak where you think it's going to be. There is a new optimal design, which is better than that. But do it that way, and you will do much better. This is where the TDM community can do a much better job. And again, here again is a change in the volume of distribution causes the biggest change in the serum concentrations at the peak. So that's the best time to sample. For the elimination rate constant, it's here when the levels are 1/3 of the peak. And the population model is the Bayesian prior. We get new data from the patient. That gives us the posterior, the individualized patient model. Here we see our software's non-parametric model of gentamicin in this case. And here we see that the dots are the tops of each model support point. If we wanted a dosage regimen to get a peak of 12 micrograms per ml, this would be what the most precise regimen for that model would do, and this would show us the uncertainty in our ability to get that peak because of the patient's diversity in the population model. So that's why we need to do TDM, to minimize that diversity in our knowledge of the behavior of the patient. So we will do multiple model Bayesian posteriors. Let's not talk about that. And we'll talk about the interacting sequential Bayesian posteriors in a minute. So here we see a patient now who has been on gentamicin, 5 levels. And let's see now what this 3rd level might be. There is the posterior model. We see how different it is from the population model. And here we see the prediction of that 3rd level. And we see that we are basically much more precise in our estimation of what's going on with that patient, having used this method of Bayesian analysis. If you use map Bayesian analysis based on single parametric models, you will not usually see this estimate of the precision with which you know your patient. Now, the interacting multiple model comes about because we assume that the parameter values can change with each new data point sequentially. And it has been shown to track gentamicin and vancomycin behavior best in ICU post-cardiac surgical patients. That's the second reference here. And here we see a patient who was acutely unstable, and here we see the fit to the data, and here we see the really very poor quality of the fit to that data. When we use the interacting multiple model, well, here then is the origin of the IMM method, and the main purpose of a tracking system is the estimation of target trajectories in the controlled area and their prediction into the near future to help you aim the guns. And here's the improved fit using that approach. Now what we're going to see is that the parameter values are going to change over time as each new data point becomes available. And here's the volume of distribution changing over that time. And we're now able to track it so that we can get the Bayesian posterior at this time the best, so that we can calculate the best regimen for the near future for this acutely ill, unstable patient. And so unstable patients have changing renal function. They have a changing volume of distribution because they also have changing fluid balance. And here we come to the issue of clearance. And many people will tell you that clearance is the most physiologic pharmacokinetic parameter value that exists. And that is simply not so. Clearance commingles the volume and the rate constant because it's their product, and you lose the actual information about the contribution of each. Clearance is an unnecessary pharmacokinetic parameter. You never need to use it. You can describe everything, regardless of mechanism, without using clearance. And you will be able to keep separate the knowledge of the volume with its implications for fluid balance and the rate constant for excretion of the drug with regard to your individualization of drug therapy. And for dialysis and renal replacement, it's good to get a drug concentration and a creatinine at the beginning and end of dialysis or renal replacement or extracorporeal membrane oxygenation. And because you're getting creatinine there, you can also estimate creatinine clearance with a pair of serum creatinines so that you can then link the behavior of the apparatus to a value of apparent creatinine clearance that it gives you. So that then if you don't have the data, you can use that information to help you understand what's going on with the patient during each of those procedures, so that we can now include all of those procedures into the history of the patient's pharmacokinetic data, so that we can take better care of them that way. Now, just like bacteria with their different MICs, patients also vary in their sensitivity. And digoxin clinical effect does not correlate with the serum concentrations, but with the concentrations in this peripheral non-serum compartment. This is data from Jim Doherty a number of years ago, and here are serum concentrations in patients who are toxic and patients who are not toxic. Look at that, 6.5. Not toxic. People vary that widely in their sensitivity to drugs, just like the bacteria do. Every person has their own MIC, so to speak, their own index of sensitivity to the drug. And these patients have to have very different binding constants of the drug to their sodium potassium ATPase in order to be able to tolerate those concentrations and to derive benefit from them. Here we see the work of Dick Rooning and his colleagues at Ohio State in 1973, from which we take the data for our population model of digoxin. It's right from their data. And here we see the plasma levels decreasing from the IV administration, and we see the concentrations in the peripheral compartment increasing and going down. And here we see the measured QT interval in the EKG, which is a reflection of the inotropic effect of the drug. And we see it following the peripheral concentrations rather than the central. And so we like this two-compartment, non-parametric model with unconstrained parameter distributions. And we plan regimens either for a trough serum concentration of 1 or maybe 0.7. But patients with atrial flutter, instead of needing a peak of 7 in the peripheral compartment, they may need 9 to 18. You have to look at each patient and see each patient's response and sensitivity to the drug. And here we see data from the literature. And the one that's most often quoted is from Falk, and it says that digoxin is no better than placebo for converting patients with atrial fib to sinus rhythm. And here's another study that says the same, and here's another study that says the same. But here's another study that shows 71% conversion with more out there. And here's another study that shows 85% with more out there. And this is significantly different from here. So follow what happens in the peripheral non-serum compartment for digoxin and compare that with the patient's clinical behavior. And then decide what you want to select for a target goal in that peripheral non-serum compartment. Here is a patient with chronic stable atrial flutter for at least 3 years. And every cardiologist knows in his soul that DIG will never do anything for this kind of a patient. But this was the first patient that happened to convert, and I wasn't expecting it at all. I was simply trying to control his rate. And here he was with atrial flutter at an apical rate of 140. And here we are giving him digitoxin, and the little crosses here are the serum levels, which you don't see well, and the top line is the peripheral compartment concentrations, and the bottom here is the serum concentrations, and this is the first month. And here we were titrating him up, and here all of a sudden, sinus rhythm, right out of the blue, at 110. Here he had a little a little 3-to-1, and here a little 4-to-1 AV block, but here now, sinus rhythm. Now at this point, he aspirated and developed an aspiration pneumonia, and everything went south. Everything went down the tubes, back to atrial flutter with an apical rate of 140. We increased his DIG a little bit, but the real thing was that his aspiration pneumonia got treated. His blood gases, which had been bad, got better, and he now came back to his sinus rhythm. And he did that 3 times during this 6-week course. And 3 times when his blood gases get better, even though we didn't do anything with his DIG after that, he came back to sinus rhythm, showing the combined effects of the DIG and his blood gases on his behavior. But we were able to be useful to him this way. Here's another patient. This is a lady, a 94-year-old lady with a transitional cell carcinoma of the bladder. And here she was one Saturday afternoon when I was covering the geriatric service with new onset fast atrial fibrillation at about 180. And here her creatinine clearance was 3.7. And she had given up. She wasn't taking food anymore. She was getting ready to die. But I gave her 0.5 and then 0.25 and then 0.25 again here. And at that point, she converted. And now the task was to give a maintenance dose that was correctly related to what I had done in order to keep her peripheral compartment concentration at the level at which she had converted. So when she converted, I came back and put the data into the software, and here we see that her peripheral concentration was about 9 when she converted, and that's what we developed the regimen for after that. And it turned out to be 0.125 8 times a week. So 1 day a week she got a double dose. That's here and here. And in that way, we were able to keep her peripheral compartment concentrations in the region where she had had them when she converted, and she stayed converted for the remaining 2 weeks of her life until she died. but we were able to do that for her. Here's another patient with new onset atrial fibrillation. He was on 0.25 once a day at this point. He missed a dose here and went into fast atrial fibrillation. Here are his serum concentrations. They gave him 4 doses of 0.25 here. This was up at Stanford, and this was all by phone. And he converted to sinus rhythm, and they put him back on his old maintenance dose, and so he excreted the remaining dig and went back into atrial fibrillation here. They converted him again with only 2 doses, and again put him on his maintenance dose, and he went back into atrial fibrillation here. They converted him again here, and now the job was to come up with a dosage regimen that maintained his peripheral compartment concentrations at that level afterwards. And the dose was a big one. It was 0.5 and 0.625 milligrams a day. And very few cardiologists would be willing to do that because it's not in their experience. But Bill Nicholson, who had this patient up there, had been in our lab, and so we did that. But you don't see the thing clearly here. Look at it with his peripheral concentration there. And here we see when he went into atrial fibrillation, when he converted the first time, back to atrial fibrillation, converted the second time, back to atrial fibrillation, converted the third time, and we said, well, he's telling us that he likes it when he's got between 11 and 13 micrograms per ml in his peripheral compartment peak. So we came up with that regimen to put him there, and it did the job, and he stayed in sinus rhythm for the next 2 weeks in the clinic. Here's another patient who did not convert because they wouldn't give him what he needed. And his serum concentrations got pretty high, but his peripheral concentrations were much lower, only about 6 rather than 9 or 11 or 18. And that's why he didn't convert. And each model seems to have their own, each patient seems to have their own relationship between serum and peripheral compartment concentrations. The population model has a ratio of 7. The lady with the end-stage renal disease had that basic relationship. The patient who converted, who needed conversion 3 times, the patient at Stanford, had that ratio. The patient who did not convert had only that ratio. So it's important to look at the patient and to follow the concentration in the peripheral non-serum compartment for digoxin, and to develop your therapy to hit a target in that peripheral non-serum compartment. Here's another nice article by this guy Bauman, and here is the overall mortality in the placebo group, and here in patients on digoxin. And here we see that there's a significant drop in the mortality with a serum concentration of 0.7. So that's probably a good target goal for a serum concentration. That's where I try and keep my wife. And she takes 0.125 5 days a week and does it that way. Now, the drug companies spend a lot of money developing drugs. They miss a lot of them don't make it, but they do prey unethically and immorally on a pharmacokinetically untrained and uneducated medical community. Look at the TV ads for the oral anticoagulants and the antiplatelet drugs. Look at them and cringe. Here's a nice article, and it says that prasugrel is better than clopidogrel. And they say because it has better outcome and more antiplatelet effect. They say nothing about the dose. Here is their publication of the antiplatelet effect. Here's the prasugrel, here's the clopidogrel. Notice that both of them cover the full spectrum from practically no effect to practically total antiplatelet effect. Do they think to ask, what is it in those who bleed? Do they think to ask, what is it in those who are poor responders? Do they think to ask, what target value could we find where patients do best with respect to outcome? No. No. And this is a well-recognized group in Italy, Dr. Antonucci, and their response to the letter to the editor that I wrote really shows the depth of their ignorance, because they say the variability is far too great, so the individualized therapy is unrealistic. Sorry, fellas. But it's the drug companies that are being unrealistic and bad guys to foist this upon us. They suppress their own data, which you see is there. And the data is there to relate each of those to outcome, and they simply did not look. And Dr. Antonucci didn't even think to look. I also asked not who sponsored the study, but who designed the study. They didn't answer the question. They only said who sponsored it. But they could have done anything, all of that. And for them to advertise that this is not needed is really, in my view, unethical behavior. And Big Pharma is like that all the way through. Big, bad pharma. You have to watch them like a hawk and try and catch them. Why do we accept that? Why do medical schools continue to teach medical students to give doses out of the package insert rather than any pharmacokinetics? There is no medical school that I know of that teaches pharmacokinetics in any clinically meaningful way anywhere in the world that I have seen. They suck it up from the drug companies, and they think their stuff, whatever that is gold. And again, here's our lab. There's Alan Chemetsky and Dave Bayard, our key mathematicians. Mike Neely, I'm so glad, my God, has he just taken this stuff and run with it. And his new version of Bestos that's going to come out maybe in a year or so has the ability to model the behavior of combined multiple interacting drug systems so that you can model drug interactions in a quantitative way and then develop combination coordinated chemotherapy that manages rather than avoids those interactions. That's what's happening with him. And here we are again. So thank you very much. Any questions? Like Mr. Nixon used to say, I hope it's all crystal clear.
Thank you, Roger, for this very enchanting presentation. And I have a question because I always feel that all the time. You talked about optimal sampling time. I always feel that when we have patients who are very fragile patients, let's say children with malignancy, and you want to do some...
I'm going to say it again, I can't hear.
Yeah, if you have patients who are very fragile, like children with malignancy, who are receiving multiple doses of different drugs, and you want to do a kinetic study for one of the drugs, for example, you have hard time to schedule a dosing or sampling times and say every 6 hours or the second day, third day, fourth day. It's unethical and unpractical. So can you just please elaborate more on how can we go over that by just choosing maybe one sample, every...
That's been the attitude of a lot of people who have to take care of kids.
Yeah.
Because they don't want to draw any more blood than they have to. But you also should think about drawing as much blood as you need to for their benefit. And acutely ill people, grown up or kids, are going to need more frequent serum sampling. They just will. When they're unstable, you need more data to track the behavior and control the behavior.
But then I can use some way of...
And that's where these optimal policies for getting TTM samples are very useful.
Yeah. But then maybe I can use your technique just to optimize the optimal sampling time, so I can identify when exactly I should draw the samples, and I know that this is the right target, and I can build a plan for that.
And another thing, if the doctor orders a dose to be given at 8 o'clock, that's a physical impossibility. No patient ever gets a dose at 8 o'clock because the nurses go around, and they have to go around and go from patient to patient to patient, giving them their drugs. All they need to do is to write down military time to the minute when they did these things, and then nobody cares when the drug was given, just so that we know when it was given. And that's the important thing.
Okay, thank you.
Thank you very much. I think your speech was very nice, and I really appreciate a lot of your things. Even I'm not Bayesian, I'm a Neumann-Pearson statistician, so I'm not so fond.
You are a frequentist?
No, I'm a Neumann-Pearson statistician, but I know that somebody's used these Bayesian models, but I don't think we shall discuss that here now. But there was one thing I'm wondering, because you stated that the standard deviation was nearly linear. It was nearly that the standard deviation was was nearly linear with regards to the dosage.
Well,
but from all my
you should react to a measurement according to a correct measure of the precision of that measurement.
Yeah.
The reciprocal of the variance of a measurement is the correct measure of a measurement that has Gaussian error distribution to it. And that's why reciprocal of the variance is much more useful than CV percent.
Yeah, I know that. It wasn't my question or my comments. It was that the standard deviation, if you see that standard deviation as you see that the standard deviation is increasing with the dosage. And that's correct, but I don't think it's linearly. It's following more a log normal, a log distribution. So it's actually flattering out. It's increasing in the beginning when you increase the dosage in the beginning. But if you increase it more, it will flatter out, and you haven't.
You're absolutely right. You're absolutely right. It's not linear, and we have that slide that shows that in that particular assay, it was a little more at the blank than it was down in here, and then it came up here like this. So you can store the information of that nonlinearity as a polynomial, so that then for any single determination, you can have a pretty good estimate of the standard deviation of the assay.
Yeah, because what I had done is that not in pharmacokinetics, but in clinical trials where we are looking into centers, and the more centers you are including, the standard deviation in the total material will increase.
I'm sorry,
but it's
more what?
The more center which you include in a clinical trial. If you,
greater than places taken.
Then the standard deviation will increase, but it's not linearly. It comes to a certain point. It's following a logarithmic deviation, and then it flatter out.
Whatever it is, you can catch it with the polynomial.
I agree. But thank you anyway. I really appreciate your talk.
Thank you very much. Thank you all.